Hello and welcome. Today we'll be discussing a rare but fascinating condition called Glomus Tympanicum tumor. This involves a growth in a very sensitive area of the ear, and understanding it can be crucial for both patients and healthcare professionals. The exact cause of Glomus Tympanicum tumors is, in many cases, unknown. However, genetics play a significant role. A familial predisposition is observed in about 10% of cases, particularly those associated with mutations in genes like the SDA-SDHC, SDHB, and SDJ, all of which are involved in the succinate dehydrogenase complex. This complex is essential for cellular energy production within the mitochondria. Certain environmental factors may also play a role, but further research is needed to solidify these links. Glomus tympanicum tumors arise from paraganglion cells, specialized neural crest, derived cells located within the temporal bone along the Jacobson's nerve promontory, which is the medial wall of the middle ear. These paraganglia act as chemoreceptors that respond to changes in blood oxygen and carbon dioxide levels. When these cells undergo uncontrolled proliferation, they form the tumor. As the tumor grows, it progressively invades and erodes the middle ear space, the ossicles, and potentially extends into the inner ear or mastoid bone. It can even extend into the cranial cavity in some advanced cases. The tumor's highly vascular nature contributes to its characteristic pulsatile tinnitus and tendency to bleed easily. Glomus tympanicum tumors are relatively rare, representing a small fraction of all head and neck tumors. Their incidence is estimated at around 1 in 1.3 million people per year. They are more commonly found in women and men, with a female-to-male ratio of approximately 3:1. While they can occur at any age, they are most frequently diagnosed between the ages of 40 and 60. The signs and symptoms of a Glomus tympanicum tumor can vary depending on its size and location. The most common symptom is pulsatile tinnitus, which is a rhythmic whooshing or pulsating sound in the ear that is synchronized with the heartbeat. Other common symptoms include hearing loss, which can be conductive or sensorineural depending on the involvement of the ossicles or inner ear fullness or pressure, and vertigo or dizziness. In more advanced cases, the tumor can cause facial nerve paralysis, resulting in weakness or drooping of the face, or other cranial nerve palsies. Diagnosing a Glomus tympanicum tumor typically involves a combination of clinical examination and imaging studies. A physical examination using an otoscope may reveal a reddish or bluish mass behind the eardrum. Audiometry is performed to assess hearing loss. High-resolution computed tomography as CT scans are used to visualize the tumor's extent and its relationship to surrounding structures. Magnetic resonance imaging (MRI) is essential for delineating soft tissue involvement and detecting intracranial extension. Angiography may also be used to assess the tumor's blood supply prior to surgery. Glomus tympanicum tumors are often classified using the Fitch classification system, which stages the tumor based on its size and extent of spread. Fish type A tumors are limited to the middle ear cleft. Type B tumors involve the mastoid bone. Type C tumors involve the infralabyrinthine and apical regions of the temporal bone. Type D tumors have intracranial extension. Another classification is the Glascock-Jackson staging, which categorizes tumors as type I, IV based on the extent of middle ear, mastoid and inner ear involvement. These classifications help guide treatment planning. Treatment for Glomus tympanicum tumors aims to control tumor growth, alleviate symptoms, and preserve hearing and neurological function. The primary treatment options include surgery, radiation therapy, and observation. Surgery is often the preferred approach for smaller tumors that are limited to the middle ear. This involves removing the tumor through a surgical approach, sometimes requiring reconstruction of the ossicular chain to restore hearing. Radiation therapy, including stereotactic radiosurgery, may be used for larger tumors that are difficult to access surgically, or in patients who are not suitable candidates for surgery. Observation with serial imaging may be appropriate for small, slow-growing tumors in elderly or high-risk patients. Currently, there are no definitive preventative measures for Glomus tympanicum tumors, especially given the genetic predisposition in some cases. However, avoidance of excessive noise exposure and ototoxic medications may contribute to overall ear health. For individuals with a family history of paragangliomas, genetic counseling and screening may be considered. The prognosis for Glomus tympanicum tumors is generally good, especially with early diagnosis and appropriate treatment. Surgical removal can be curative for smaller tumors. While larger tumors may require more extensive treatment, long-term control of the tumor is often achievable. Recent research is focused on identifying novel genetic mutations associated with these tumors and developing targeted therapies. For example, new investigations explore the use of tyrosine kinase inhibitors or other drugs that can target the tumor's blood supply or signaling pathways. These advancements hold promise for improving treatment outcomes and reducing the morbidity associated with Glomus Tympanicum tumors. Additionally, advancements in surgical techniques and radiation therapy have led to improved outcomes and reduced complications.